But with that, I'm really very happy and grateful to announce that the next speaker on chest clearance techniques, Charlotte Massey, I don't know if I pronounce your name.
Yeah.
Thank you so much. Is with us, and she's a specialist physiotherapist from the National Hospital for Neurology and Neurosurgery. The floor is yours for patients. This is a super important subject because we all know how it feels when you're not able to clear your airways. So thank you. The floor is yours, Charlotte. Thank you again.
Thank you. I'll just share my screen. Okay, hi everyone. My name's Charlotte. I'm a physiotherapist and I work at the National Hospital for Neurology and Neurosurgery. So I've been asked to talk about chest clearance techniques in adult Duchenne muscular dystrophy. So some of this has already been kind of touched on in the previous presentation, but what we're going to talk through is, first of all, I'm just going to cover why the cough is weak. And again, this was briefly talked about, but it's a combination of both inspiratory and expiratory muscle pathology with weakness, which affects the diaphragm, intercostal and abdominal muscles. So effective cough is a protective mechanism against respiratory tract infections, which, as we've just heard, are the commonest cause of hospital admission in these patients. So when we're thinking about cough, we need to think about three main things that are included. Firstly is the inspiratory muscles. So this is predominantly your diaphragm, but also muscles which might elevate your ribs and your sternum, such as your intercostals or your accessory muscles, which are here around your shoulders. And then we need to think about expiratory muscles. So these are your abdominals and your internal intercostal muscles. And we know that these are also weak in these patients. And lastly, we need to think about bulbar function and ability to be able to generate that cough. And I'm going to talk through the stages of cough in the next slide. And when we're thinking about cough, we're thinking about the respiratory center as a whole. And the two main things we think about is the capacity, which is the capacity to breathe and take big breaths. And the main things impacting this is the muscle weakness, so the neuromuscular weakness. But really importantly, we also need to take into account the load on the respiratory system. And that can be split into two parts. Intrathoracic, so that is things that sit inside the lungs, so that might be secretions or phlegm. And then also thinking outside the lungs, extrathoracic, and that is really important when we think about posture, maybe whether there's a kyphosis or a scoliosis or something that might be affecting the chest wall. So the stages of cough start with an irritation, so something irritates. At that point, you will then take an inspiration, a big breath in, and normally this is about 90% of your total lung capacity. So you breathe in, you use your diaphragm, take a big breath in. The next stage is where your bulbar function is really important. So you will get closure of your glottis up there, and that will build compression and pressure within your lungs and your thorax. And the last stage is expiration. So at this point, what happens is your glottis opens really quickly and you get a big push up using muscles, including your abdominals, to be able to push and cough out and clear any bits of phlegm that are sitting there. So why is this important in Duchenne? So we know that respiratory muscle weakness can lead to atelectasis. So that's kind of collapse down in the bases of your lungs, so some lung collapse, and also retention of secretions because your cough is not effective to clear those secretions out. And as we've just talked, this is due to this inability to generate these effective inspiratory volumes to be able to get a big breath in and get air behind those secretions. and also to be able to generate a peak cough flow that's high enough to be able to clear those secretions. And we'll talk a lot about the peak cough flow and the readings of that, because that often informs us as physiotherapists what is the best way to support a patient's cough. And then we know that recurrent respiratory tract infections can result in weakened respiratory muscles, which then turns into a vicious cycle. So our aim is to try and prevent any respiratory tract infections by providing support to be able to increase inspiratory volumes and increase peak cough flow. So what are our interventions, and when and what are we going to do? So I've picked out two things here. So one is the DUCHENNE standards of care, which Professor Quinlivan touched on earlier. And the part I want to pick out here is where it talks about lung volume recruitment when FVC less than 60% of predicted. So that is something to be able to get a bigger volume and try and recruit your lungs. And underneath that, it talks about assisted coughing when your forced vital capacity is less than 50% or your peak cough flow is less than 270 litres per minute. And I'm going to talk through what the options are to assist coughing in a second. And then I've also picked out this, which is from an international workshop in 2017. And this is for neuromuscular patients as a whole. It's not specifically for Duchenne, but it very nicely talks through where we would need to support and assist a cough, where we would consider a need for an assisted cough, and where we would have no need for an assisted cough when we're looking at peak cough flows and forced vital capacities. And I'm going to talk through what the different options are. So when we're thinking about chest clearance techniques, and this table has come from the work of Michelle Chatwin and a group back in 2018, we think about our respiratory physiotherapy techniques and we think about airway clearance techniques. We can split them into two parts. So the first part is what they're calling proximal airway clearance techniques, or cough augmentation. And these ones are the ones that are really important when people have any sort of neuromuscular weakness, so any sort of weakness for the respiratory muscles, because these are the techniques that are going to support to increase the strength of that cough and make that cough stronger. On the other side, we have what they've called peripheral airway clearance techniques, or sputum mobilizing. So these are things that move sputum within the lungs, but they don't necessarily support to clear that sputum from the lungs out of the mouth. So some people will have a combination of the two, but the majority of people with neuromuscular weakness, their focus will be on trying to augment that cough. And the options for cough augmentation. Now, I've put lots of pictures here of different devices because different countries will have different devices. If we start back at the beginning, so things that can increase maximal inspiratory capacity. And if we go back to this slide here, this is these are the ones we're talking about here at the beginning, where somebody has an okay peak cough flow and we want to give them a little bit more support. So at this point, we would be thinking somebody has a peak cough flow of less than 270, but more than 150. And we're thinking about things that we can do to support getting more air into their lungs to increase their inspiratory capacity. And the first technique is something called breath stacking, which you can do with or without a lung volume recruitment bag. And the lung volume recruitment bag is that green bag there with a tubing on it. And what the patient does here is they will take a big breath in and hold the air in. Take another one on top, take another one on top, and stack those breaths to get a bigger breath in. And they can either do it themselves or with the bag if they need a bit more support. And another way of thinking about increasing this inspiratory capacity is when we're thinking about a cough assist machine, which all these pictures are here, different options of cough assist machines, is the first part of the cough assist where you're pushing air in and giving the person a big breath. The next thing we think about is something to increase the expiratory part. So when we looked at the cough, we saw the inspiratory part and then we saw the expiratory part. So at this point, we're thinking, what can we do to help that person cough more stronger? So the options are a manually assisted cough, which is a carer popping their hands just underneath the ribs and providing a bit of kind of support there as the person coughs, or the exsufflation cycle of the cough assist. And that is where the cough assist will switch from pushing air in to sucking air back out. And that change in pressure is what helps support secretion clearance. And then you can combine these techniques. So you can combine something to increase the inspiratory capacity with something to increase to support the expiratory muscle augmentation. And the best example of that is a cough assist, which gives you inspiratory support and then switches to expiratory support. And as was mentioned on the previous talk, it's really important that people are aware of their chest management plan. And these should be individualized and personalized to the patient. And this is just an example of something that we would give out where I work, where the person is aware of what their peak cough flow is, what their forced vital capacity is, and then what they're going to do day to day to help keep their chest clear. And then also a plan for what they're going to do if they become unwell, which, as we saw in the previous presentation, it's really important to have a chest management plan and know how you can support your cough if you become unwell. We also include on the back there, a bit of a traffic light system so that people can start to pick up when they're not feeling so well, and it gives a few instructions about what to do at that point. So the main take-home messages from this presentation are thinking about when forced vital capacity drops or peak cough flow drops below 270, at that point, we should be thinking about cough augmentation and what we can provide individualized for that person. When a peak cough flow drops below 160 litres a minute, an MIE or a cough assist device should be considered. And cough augmentation should always be considered if there's a history of recurrent chest infections, even if the numbers, the peak cough flow is sitting higher than this 270 mark. We should be thinking about what we can do to support that patient's cough and their chest clearance. And as we've discussed, the aim of cough augmentation is to increase your maximal inspiratory capacity and reduce this risk of atelectasis, so collapse at the bottom, as well as improve your peak cough flow. And there's a few references there that I've used, and I'm happy to take any questions.